We are very honored to be joined by a CLF advisor, Dr. David Reiss, on the call. Dr. Reiss is a psychiatrist with decades of experience helping patients with MTBI support and also helping patients with suspected CTE. Dr. Reiss has been absolutely essential to our CLF helpline, to informing our peer support programs. And we can't thank you enough, Dr. Reiss, for being here to talk about the typical mental health services that are called upon for patients navigating brain trauma.
My pleasure. Obviously, there's a lot I could say. I'm going to try to make it as concise as I can. I have a couple little graphics. I'm very busy, don't worry about it, but just to make it a little more interesting. Just real quickly, I've been involved in sports psychiatry, and so med school with the Northwestern football team of '77. So yes, it's been decades, and things have obviously changed a lot. I go back to the days where if someone went down on the field, you asked them two questions: how many fingers do I have up? And are we going this way or that way? Correctly, they stayed in the game. Obviously, a lot changed. Still a lot changing every day. I'm just going to talk a little bit about basically what makes my job very challenging. And I'll just say to that a little bit of a biased point of view, because people who respond well to the typical interventions won't get to me. So I think I'm seeing a lot of people, and I think most people don't respond typically, but I do have a biased view of being the one who gets the tough cases, basically. Let me see if I could share my screen here. Is that too much problem? Okay. Can you see that? That's a very busy slide. I'm not going to go over all those things in detail, just to give an idea of the different types of issues that we're dealing with, and what I'm going to talk about briefly is how they interact, which is what makes it difficult. So, just very simplistically, realizing that every person is a unique individual in terms of the nature of the injury, personal neurochemistry, and how they react, what you were starting with to begin with, innate temperament and personality, personal life circumstances, personal history, and that includes trauma, physical injury, impairment, disability, etc. The availability of a support system. And one of the things I run into a lot is the availability of medical care and integration of medical care, particularly on the meds. I can't talk to the neurological aspect of that, but on the psychiatric side, finding someone who has experience dealing with the issues and is up to date and is willing to innovate, as is almost always necessary, is not easy. All of these factors interact in both positive and negative ways in terms of the reactions to injury, psychologically, neurologically, personality structure, underlying issues. And some of the interactions are positive, where you'll deal with one issue and it will help another issue. And some are paradoxical, where if you help one issue, another gets worse. Sometimes if someone's dealing with trauma, you dig into the trauma, sometimes it creates more anxiety creates more confusion. So it gets pretty complex, especially when you bring in medications, which I'll talk about in a little more detail, not in terms of specific meds, but just that people with head injuries generally don't respond typically to the meds we usually use. And the athletes in general, first responders, people who like to get a rush at times, tend not to do well on some of our typical meds. So the most important thing is an individualized treatment plan. And that, when I say individualized, it really has to take into account all these factors. I'm going to switch here something a little less cluttered, a little more easily readable. You know, basically, these are the four factors that we're dealing with all the time. First is the psychological reaction to injury, not without even getting into the neurological aspect. And there you have just the person's response to feeling cognitively impaired, finding differences in their level of functioning, and functioning both in terms of externally with others, with relationships at work, but also internally, just how they view themselves and just how they're able to process information. Obviously, anxiety and fear over prognosis, especially when the initial treatment interventions either don't work or make things worse. And then just the obvious typical disruption of activities, disruption of interpersonal relationships, and very importantly, disruption of self-esteem. Who, I'm not the person I'm used to being. And how do I come to terms with that? Am I going to come back? When am I going to come back? And one thing I'm always working with people with is it's not a straight line. There are ups and downs. There are always going to be bumps in the road. Then we get the neurological issues where you can get changes of mood, anxiety, and depression that are purely on a neurological basis. Do we totally understand exactly what's happening? No. Sometimes with taking brain scans, neuropsych testing, etc., we can sort of get an idea, but we really don't understand completely why there's a neurological aspect of causing anxiety and depression above and beyond the psychological issue. Similarly, as I don't really need to tell you, I'm sure, is the impact on just the basic neurological response to issues, irritability, temper, anger. And it can go in either direction, but often it goes in making people more labile. It may scare others, it may scare them. And we have to watch out in terms of medications, which way we go with that. That's something that we always have to take a look at and often worry about because it can get dangerous. Obviously, neurologically based impact upon decision making and judgment, which can affect how someone responds to intervention and treatment beyond just the trouble they get into, which I don't need to go into detail. And sort of related to what I just talked about is neurological disinhibition of control, behavioral control, impulsivity, also cognitively, obsessive thoughts, not being able to keep track of thoughts. That isn't psychological, that's on a purely neurological basis. And there are some of the interventions we may use, if it's purely psychological, will make the neurological worse, like some medications, and the reverse. Hopefully we could find for the individual program where everything works together as best as possible. Third issue I'd like to talk about is the exacerbation of basically what's going on in a person's life to begin with. I mean, especially these days, very few people are on clear sailing before they get injured. So who are we working with? What's going on in their life? What's going on in their relationships? Do they have pre-existing anxiety and depression? All of those factors come into play. And then also the fourth thing is the triggering of repressed issues, something that someone may not be aware of or they're aware of and they usually cope with, but whether it's on a psychological basis or on a neurological basis, basically the covers come off. In technical language, the psychological defenses are disrupted. And this can be due to underlying PTSD or trauma that someone is or isn't aware of, changes in a person's sense of identity when they're not functioning the way they used to, obviously loss of self-esteem, loss of interpersonal trust, which may be because of how people react to them differently due to their injury, or maybe due to a paranoid process that has a neurological aspect. Uh, Changes in issues or triggering of issues of dependency and independence. People often lose a lot of their independence. And it may be someone who was just floating along and had their life in reasonably good positions. Suddenly they're dependent on doctors, friends, family, others. That can bring up other issues that weren't obvious previously. And also, not uncommonly, leads to loneliness and a feeling of isolation or abandonment. I'm just touching on these issues. Obviously, I could give a whole seminar on each one of them. The main takeaway is that all of these issues interact. And they interact in ways that, as I say, that are both positive and negative. The most obvious and problematic one at times is due to the injury itself and due to any of the above issues, person may not have motivation for mental health treatment, may not realize they need it, may not want it, may be afraid to go. So all of those issues can combine to decrease motivation. The ability to accept support. If there is a suspiciousness or paranoia, support may be there, but it may not be trusted. And whether we're talking about support from friends or family or clinicians, the ability to accept it, the ability to willingness to make oneself open and available may all be negatively impacted by the injury, which goes beyond dealing with that issue. If someone just came to me and said, hey, I have problems with, let's say, loneliness and anxiety, very different when you're dealing with other issues that cognitively get in the way. Similarly, the ability to make use of psychotherapeutic intervention, whether you're talking about basic CBT, just being able to be consistent, being able to follow instructions, being able to understand instructions. And then, often when someone's injured, it's not the time to dig deep into previous traumas or previous issues. But if they raise their heads, sometimes you have to. And that is a difficult tightrope to walk. How much do you get into things when someone's ability to deal with it may be compromised? You can't ignore it. You have to acknowledge it. Sometimes if you tell people we'll get into it deeper later, but let's just get things stable. Let's sort of, get the boat sailing before we start looking at the engine. Sometimes that will be accepted. Sometimes that's seen as the rejection or a lack of understanding. And then the response to medication. I'm not going to go into specific medications, but basically a lot of the medications we typically use don't work or cause problems, or we have to use in different dosages. The most obvious thing is a lot of psych meds, whether we're talking about for anxiety or depression, can cause subtle cognitive impairments. Just subtle problems with memory, subtle problems with thinking. In a typical case, if someone comes into me depressed, let's say, or acutely depressed, they may have a little memory problem due to the medication, but that's a pretty good trade-off for feeling better. On the other hand, if you're already struggling with cognitive problems due to your injury, you're going to be more sensitive to the medication and to realizing that the medication is causing more of a problem, because what under normal circumstances may be a minor inconvenience now becomes an exacerbation of a significant issue. So that's counterproductive. With all the medications we use, there can be overactivation, there can be disinhibition. The benzodiazepines can make people, lose control. Addiction, obviously we're always dealing with that. And dealing with antidepressants, people with head injuries are more susceptible at times to become more angry, more irritable. Obviously sedation at times is the problem. And if you're already dealing with cognitive problems, that makes it worse. And then the other thing that people often don't realize, particularly if someone just goes to a neurologist who doesn't deal with, let's say, athletes a lot, or people who, as I say, like to have a bit of adrenaline rush, most of the antidepressants we use tend to dull all emotions. A lot of times they'll cause sexual dysfunction. That's the last thing a lot of these people want to experience. And they may feel relief initially, but a week or two later, they're feeling flat. I can't enjoy anything. I can't perform sexually. Where did my feelings go? The worst cases I've seen, and it's not all that infrequent, is where, a doctor will say, well, let's double the meds because, you're still depressed, but doubling the meds makes them even flatter. And then you can get people being more impulsive to try to break through that flatness. So that's something we're always walking a tightrope on, is we don't want to overactivate someone whose judgment may not be the best. But on the other hand, we don't want to dull them to where they start getting involved in risky behaviors just to try to feel something. And then the last one, which is very obvious, is just that the physical, neurological aspects may get in the way of normal self-care or responding to CBT type instructions in self-care. Bottom line is it's very complicated. There's no one size fits all. Most of the people I see, I'm innovating. I may be using a medication that typically isn't used. Some people will respond to one or not another. And the type of therapy may be anywhere from classical therapy, just chatting at times, to just being there and knowing when to do each. So, psychiatry is always complicated because we're always dealing with a lot of different issues at once. It's never a straight line. It's always intermingling factors. But when you're dealing with someone post-concussion, on steroids, sometimes literally. I'll just add one other thing that's often a complicating factor these days, especially now that it's legal, is the use of weed, marijuana. I don't doubt that there are some chemicals in marijuana that are helpful. There are others that definitely aren't. If you're getting it off the street, basically you're playing Russian roulette. And even if it is helpful, it tends to impair memory under the best of circumstances. Obviously, that's not what you want to do with someone who's already dealing with memory problems. So, just a little presentation to give an idea of the complexity of what we're dealing with, that there are no easy answers, and open to any questions,